All right, welcome to the Clinic AI Academy Journal Club, and today we have a paper to discuss that is published in the Lancet Digital Health, titled "Artificial Intelligence Imaging Decision Support for Acute Stroke Treatment in England: A Prospective Observational Study." We hear a lot about AI reading scans better than humans, but the real question is, does AI actually change what happens to stroke patients? For example, in this case, stroke patients or patients in general. So does it get more people in that case to thrombectomy? And does it do it faster? So today I'm going to discuss this large real-world study from England that tried to answer exactly that. But before we dig deeper, let's try and define two important things mentioned in the title. First one, what does it mean when we mention a prospective study? So a prospective study is a design of studies which follows the participants forward in time. So it is kind of a longitudinal study that follows participants forward in time to compare the incidence of outcomes between exposed and unexposed groups. In that case, people who were screened with AI compared to people who were not, thereby assessing temporal associations between exposure and outcome. And the other thing mentioned in the title was also observational study. So when we say a study is observational, that means that the investigator does not assign exposure or interventions, but instead observes and analyzes the natural variations in exposure and their associations with health outcomes as they occur in real-world settings. So now we have the definition of prospective and observational study. So it means that they followed patients for some period forward in time, and then they observed what's going on when they're exposed to being screened with AI versus not screened with AI. In that case, for decision support for acute stroke treatment, whether they get endothrombectomy or not. So the background of, as mentioned in the study, is endovascular thrombectomy is a standard of care for patients with large vessel occlusion stroke. And artificial intelligence AI imaging software is increasingly used to support identification and selection of patients with stroke for this treatment. In this study, we aimed to evaluate the effect of AI stroke imaging software on endovascular treatment in England. So what they found as a conclusion, that the stroke AI imaging software was associated with increased endovascular thrombectomy rates across the English NHS, and these results support the routine use of AI imaging software in the management of patients with stroke. So if we look at this figure here, which is the proportion of patients with stroke receiving endovascular thrombectomy as a function of time or date of presentation, and you can see here there are two time periods, where the pre-implementation of the AI period, which is like from 2019 to 2020, and then here post-implementation period, and we have two lines. The blue line is the evaluation and the non-evaluation. So this is figure number 1, endovascular thrombectomy rates per month in the evaluation and non-evaluation sites for all patients with primary diagnosis of stroke admitted to hospitals in England. And then the total patients across this time period were around 500,000, like 500,000 people. So what they found that actually hospitals using AI imaging treated more patients with endovascular thrombectomy than those that did not. So those are the evaluation sites, the ones that can see here the ones that were screened using AI versus the one that did not use AI. So percentage of patients receiving endovascular treatment was higher with AI than without AI. That means when AI was implemented, thrombectomy rates doubled at those hospitals compared with a similar increase at hospitals without AI. So like there's an increase in general, as you can see, but the rate with AI even increased. And even they counted for post-COVID, there was an increase in general in like stroke post-COVID-19. And then this does not explain the increase in those rates based on their discussion. So even when looking at individual patients within the same hospital and time periods, patients whose scans were reviewed with AI were significantly more likely to receive thrombectomy. That suggests that this was not just a background trend in stroke care. AI use itself was associated with more patients getting treated. Interestingly, the benefit of AI was greater in primary stroke centers than in comprehensive centers, which makes sense. These are settings with fewer stroke specialists, so less immediate access to expert imaging, interpretation, and higher risk of missing a treatable large vessel occlusion. So in other words, AI seems to help most where the system is weakest, not where expertise is already concentrated, and this is positive news. So the most clinically relevant finding was also about time. In neurology, we know that time is brain, so you want to treat as soon as possible. This figure 3, shows that door in, door out time. So this is on the y-axis, door in, door out time in minutes, and AI software used the no here and yes. So this is figure 3, door in, door out times in patients where AI was or was not used in image interpretation at evaluation sites after implementation. And you can see that with AI, it is the time is shorter. So for patients who first arrived at a primary stroke center and needed transfer to a comprehensive center, AI used shortened door in, door out time by over an hour. So this is a huge deal in stroke. Time lost is brain lost, and delays at first hospital are a major bottleneck in real-world care. So the clinical outcomes and limitations mentioned in the study. So patients assessed with AI had better outcomes at discharge, which is consistent with higher treatment rates and faster care. However, long-term outcomes were not available, so we should interpret those findings cautiously. And this was also an observational study, so it cannot prove causality. There were baseline differences in stroke severity, and implementation itself may have changed clinician behavior. So the authors addressed this with statistical adjustments and sensitivity analysis, but residual confounding is still possible. So the key message here is that from this study, from real-world evidence, a prospective observation study, is that we are moving from beyond AI reads scans well to AI changes stroke pathways. At a national level, in routine clinical practice, AI imaging support was associated with faster triage and better access to thrombectomy, especially in primary stroke centers where expertise is not concentrated. That's strong real-world evidence supporting current guideline recommendations to integrate AI stroke workflows. As usual, you are more than welcome to join our education activities here at the Clinical AI Academy, this online, open source, open space, transdisciplinary, community-driven platform to learn more about clinical AI. Together, learning is more rewarding and fun. If you have papers to suggest or you would like to present them for the Journal Club, we are more than happy to hear from you. And if you want to present your own work, feel free to reach out. That would be great. I'll leave the email that you can reach out to us in the description. Also, I'll leave the link to the paper we discussed today in the description. And thank you very much.